Hello and welcome to another Wilmington Healthcare Coffee Conversation, and I'm joined by my new colleague, Roger Tomlins. And we're going to talk today about something I can't believe we've not discussed already, which is population-based healthcare, really big topic that's everywhere at the moment in
Indeed.
the NHS and the long-term plan. So what do you make of this term? What does it mean to you? Is it different to place-based healthcare, or is it the same thing?
Well, so I think the two terms can be used interchangeably. Place-based care and population-based care. There are some new buzzwords that have been around for maybe a year or so. And I think people have been talking about them a little bit more since we had the long-term plan shared at the beginning of the year. And Ollie, we've probably been moving in that direction for a number of years anyway. You know, we talk about a very rigid healthcare system in many ways, certainly up until, let's say, when Simon Stevens joined as chief executive in 2014. You had very clear primary, secondary and tertiary care healthcare organisations. And people sort of moved, or patients moved between the three in various different ways, but they still operated independently. What I think started with the 5-year forward view and the growth of trying to organise healthcare around a geography with sustainability and transformation partnerships, attempting to bring these organisations together to look at how they could design care for the people living within a particular geography. Place-based care is that almost by another name, and it takes it to another level, if you like. But essentially it is around the commissioning and the delivery of health services. It's bringing those various organisations together, joining forces, if you like, but focused on a particular population.
Souped-up integration.
Yeah, absolutely. It is simply that. It's about integrating these organisations that have hitherto existed in many ways, still even today, in siloed operating.
Sure. Okay.
But
so why is it needed? Like, what's it for? What's it trying to achieve? So is it just a buzzword, and is everyone thinking, oh, if we do population-based healthcare, it's probably going to work?
Well, I mean, Ollie, I think it's not a question of doing population-based care or delivering place-based care. It is really how we ought to be thinking healthcare in itself needs to evolve. You know, we talk about having or wanting to have a sustainable National Health Service for now, fit for the future, for the next 10, 20, 30 years. And we've got to try and make sure that the services that we are accessing, that you or I are accessing, are suitable. Yeah. And what we're talking about here is ensuring that you have got a system that is integrated, that's designed around a population need. So when we talk about place-based or population, we're talking about a better understanding of the health needs within that local population. We tend to still access, you know, health services when we're ill. What this is attempting to try and do, what the long-term plan is trying to do, is to move some of the services that traditionally have existed in secondary care as specialist and emergency services. It's shifting that to a sort of community out of hospital prevention approach. And if you understand your local populations better, what their needs are, what the prevalence or the disease burden would be within any particular demographic, you're then better able to understand what services actually need to truly be commissioned and delivered to A, suit that disease burden, and B, help reduce it.
Right. So a lot of the work, I imagine, is the data at the beginning and looking at the patient populations you have and what's wrong with them and the cohorts and what services they need, and thinking about it in the round rather than thinking about we need to fund this hospital or that surgery.
Exactly. And by bringing these organisations together in an integrated fashion, you're better able to understand what that whole care pathway should look like.
Right.
Does it actually need to stratify, you know, primary care, secondary care and a specialist tertiary centre, or are there ways that we can actually deliver it slightly differently? How can we also, within that, better educate the patient, inform the patient, and ensure that they understand the better ways or the new ways they could A, treat their own condition themselves, and also when they need a specific interaction, where they go to get that, as opposed to traditionally going into a hospital care setting.
Okay, so empowered patients.
Yeah, absolutely. And I think with the long-term plan, there are a number of key priorities that have come out from that, which I think health services are understanding or needing to understand, and I think pharmaceutical industry need to understand exactly what the direction of travel is, and it is very much around reducing unwarranted variation within, say, a specialist service, and it's also about reducing the need for that onward specialist referral in the first place.
Right.
So it's very much focused around preventing and then initiating a faster diagnosis. Right. So you also then limit any escalation around a particular disease that then means it's more costly within a particular care setting. And I think there are ways also with understanding emerging technology that's out there, how we can continue to expedite diagnosis, how we can continue to inform and educate a patient so they themselves take on that mantle of self-management.
Yeah. So how the LTP, the long-term plan, is all over this as well. Is it up to individual health economies to discern how to carry this out and how to improve the referrals and do it in their own way? They've got some independence on what works for them. Yeah,
absolutely. And I think, Ollie, it's probably worth mentioning that the long-term plan, in many ways, it's new in the sense that, we're actually for the first time in healthcare talking about a medium or long-term view. We've always tended to think about things over a 12-month cycle, haven't we? If you still think about commissioning traditionally, it's been over 12 months.
Yeah.
What the long-term plan does is evolve what was the 5-year forward view from 2014, where we were actually thinking about, okay, what does the next 5 years look like, or what should it look like for the health service within the UK. And actually Simon Stevens had already set that conversation in place around what is it that we need to do that's more focused on populations.
Yes, so we're quite far into this conversation.
Yeah, I think so, and the long-term plan reinforces that, and it gives us a nice framework in terms of the sorts of priorities that we want to look at, so reducing hospital care and reducing that need, moving some of the care into the community, and utilising the digital technology or the growth of digital technology. Alongside that, it gives us very clear clinical priorities around stroke, diabetes, cardiovascular disease, and mental and maternity health. So that these organisations and these partnerships that exist now between these organisations are already making steps to ensure that the services they provide are more focused on their local populations.
Okay, I want to bring in the industry question because I know that you've got some experience in that area. So I want to tease out the implications in general of this for industry, but also talk a bit about your work in trying to engage with population-based healthcare and what's the route in for pharma industry.
So Ollie, I mean, it's an interesting question. I'm glad you asked that. I mean, in terms of existing ways of engaging with the NHS, the pharmaceutical industry can be quite successful, particularly if they come together around a common goal. And there's the joint working framework that allows pharma and the NHS to come together around identifying a particular patient need, how they could improve a particular care pathway, for example. And it's quite current when you're talking around doing that, particularly when you're focused on a population. We've got these growth of sustainability and transformation partnerships. Some of those have already moved into what we're calling integrated care systems, and that is where you've got the various NHS organisations, primary, secondary and tertiary care, operating together, pooling their resources to try and determine, okay, we understand, or we think we understand, what our disease pressures are, given our local population, what is it that we can do differently? And actually what pharma can do sometimes is come in and help accelerate some of that thinking.
Okay. So and who did you talk to? What was your entry point when you did this partnership work?
So part of my background recently has been working within the cardiovascular disease area, and something like atrial fibrillation, it can be a huge burden on the patient and those individuals who are commissioning the services and ensuring that the patient gets access to the right medicine in the right way. But it has also been a very traditional GP referral into secondary care, go and see your cardiovascular specialist. I was fortunate enough to be living and working in one of the more advanced integrated care systems, Dorset particularly.
Yeah.
And we've had a number of good relationships with some interesting individuals who wanted to try and do things differently. So we were able to set up some conversations utilising the joint working framework around if we were to look at existing hospital-based AF care, what is it that we could do differently?
Yes.
And so there was an opportunity to bring our resources and knowledge, if you like, from in some ways, a purely project management perspective around the clinical expertise, using things, latest evidence-based practice from the long-term plan. How can we make sure we're actually setting up a service that will last?
Yes.
That is, to use the buzzwords, fit for the future, or provides a bit of sustainability back in the system.
Yes.
And so we broke it down into a number of different areas, and we wanted to specifically look at how we could inform the patient, how we could educate the patient around their disease. One of the things that we discovered quite early on is that sometimes these interactions that a patient may have with a clinician operates in a very time-limited fashion.
Yep.
And so sometimes they come in, the first they know about it is the diagnosis they're given, and then they're literally discharged back to their GP to go and pick up their medicines. They don't really have time to understand, digest.
So this is where the empowering comes in.
Exactly. So one of the things we wanted to make sure when we were looking at if there was a potential for a project, that we built in that patient education piece.
Yeah.
We built in some very specific expertise, clinical expertise, so that patients had the opportunity from an extended appointment time, but also the opportunity to dial back in to that service if they had any further questions.
Right.
We also wanted to make sure that from a primary care perspective, there was increased education around the management of AF, for example, and so how you could introduce that earlier into the patient pathway. And one of the things we were also quite keen on doing is understanding and utilising some of the electronic and digital resources that were there, so that we can try and keep patients out of hospital for longer. And actually understand if there are ways we could utilise satellites, so bringing some of that care closer to the patient. And actually, something like a joint working framework, Ollie, allows you to bring all of that together because it's very much focused on the patient.
So there's cause for optimism here. I mean, did you get good outcomes?
Well, I mean, so Ollie, I can't.
Is it still happening?
I can't really comment on that. It's still happening.
It's still happening.
One of the things one of the last things I did before I moved into this role was ensure that it was up and running.
Yeah.
And where I think we took quite a bold step was actually looking at nearly a 2-year project window.
Right.
Sometimes with pharma, there can be a bit of reluctance around engaging for a medium term.
Yeah.
So actually to get a company and supporting a project around nearly a 2-year window was quite exciting.
Okay, so if we move to our sort of final take-homes, I would probably put that in there. Then if you're going to do this kind of engagement work with population-based systems, commit to it and see it as a medium to long-term thing.
Yeah, absolutely, Ollie. I would echo that again and again, because I think what pharma needs to do is recognise the language that the NHS is facing as well. And we are talking about a long-term plan. With some of these diseases, like cardiovascular disease, it's a long-term disease. How can we manage it better? How can we equip the patients to live with it longer and enjoy a higher quality of life?
Okay. Well, I think we've covered that pretty successfully. Big concept, population-based healthcare. That was Roger Tomlins. I'm Ollie Hudson, and this is Wilmington Healthcare Coffee Conversations. I hope you like that one. Bye.